Hello, I'm Dr. Chong Hyun-jung. I'm with the Yonsei Hill Dental Office. Everything is changing so fast. At the center of that lies digital. The same goes for dental treatment. Digital implant is complementing the disadvantages associated with the conventional surgery. So it's going through a lot of transformations. Let's have a look at the accurate and convenient digital implant surgery. Digital implant surgery is widely used. That means a guided template is used during the surgery. Why is it getting so popular? Let's look at some of the reasons why. Next, if the guide template is not accurate, sometimes errors can occur. Therefore, a guided template that can be used safely is the most important thing. Then, CBCT data and the surface scan of a patient should be merged together properly. Today, we are going to look at how to manage the data set. Lastly, what would be the proper indications in the basic level? And let's look at what are the big benefits that it can bring.
그럼 지금 시작합니다.
Digital surgery using a guide template, is it really helpful clinically? Can we really trust it? I really believe so. Down the road, only except very few cases, the guided template will be more and more widely used. Then, why would I like the guided template using surgery? Because if the data is merged properly, implants can be placed at the ideal positions faster and more accurately. If you use the guided template as in the right, you need to have appropriate drilling kit for the guide. This special drill barrel comes in contact with the guided template as it enters into bone or expand the drill hole in the planned position without errors. However, on the left, in the case of the conventional surgery during the drilling, a stable rest is needed, so you need to be more careful in placing the implant. Then it will become the center point and the drilling path will become in an arch form, creating some errors. That is the problem. If the surgeon is not very skilled, the probability of making errors is bigger in more areas. Then, the gap between the guide part of the drill and the template is 0.1 millimeter. It can be placed much more precisely as planned than the manual placement. That is important. Then, what are the ideal positions that are planned in advance? First, labiopalatal position of an implant affects implant's long-term survival and aesthetic factors, especially in the anterior region. Placing implant according to the extraction socket is a common mistake. It depends on the appearance of bone in a patient, but in most cases, it should be placed close or into the palatal wall to preserve the volume of the buccal bone to make more aesthetic definitive prosthesis. However, if it is placed too palatally inclined or if it is sliding to the lingual cortical bone in the extraction socket, if the center line of the implant is too much palatally inclined, sometimes it can invade the tongue space. Therefore, you need to be careful. So the prosthesis will be fabricated looking like a labial cantilever. However, as you can see, if you use guided surgery, on the program, after final prosthesis appearance is rendered, ideal positions in terms of prosthesis and surgery can be visualized. And if they do not merged properly, the final implant positions can be determined in the next best positions. So much more precise treatment planning is possible. Surgery can be done accurately and fast. Before surgery, temporary prosthesis can be prefabricated. That's like killing 3 birds with 1 stone. Next, accuracy of mesiodistal implant positions can affect aesthetic factors. When many implants need to be placed, distance between the implants affect the implant's long-term survival. The narrowest space for implant placement can be found in the lower anterior region. In most of the cases, one-body narrow-type implants are selected. Osstem's one-guide system is very helpful in placing narrow implant accurately using the 1MS kit. At the lower anterior region, flap handling and implant placement should be done very carefully as the submental artery runs in the lingual side of mandible. I use MS implant. For the placement, I mostly use one guide system. As you can see, even when roots are bent or the axis of adjacent teeth is not favorable, I also use this as accurate placement is ensured. The vertical position of implants, that is the distance from the platform to the top plane of tissue, greatly affects long-term survival and health of tissues around the implant. Biologically, it is called biologic width. In general, the vertical position of an implant should satisfy 3 rules. First, to put it simply, is platform of fixture and its relation to bone surface. Rule 2 is the relation of a platform and a soft tissue. Rule 3, the relation of platform and occlusal plane. First, these days, internal taper connection is used a lot. That is a TS implant. Based on that implant, the platform should be placed at least 1 millimeter inferior to the bone surface. It is the platform switching concept. This is to prevent bone resorption around the implant when it is used for a long time. Second, from the implant platform to soft tissue surface, it should be at least 4 millimeters. That means the total tissue thickness should be 4 millimeters or more. More intuitively, if the soft tissue is 2 millimeters, edentulous ridge. In that case, it should be placed at least 2 millimeters below the bone surface. Therefore, the biologic width of 4 millimeters should be secured to increase the clinical predictability. According to the 1991 Bug-Rund experiment, still quoted a lot, the soft tissue around the implant is 4 millimeters and 2 millimeters of the soft tissue is cut. Around the implant, the bone was resorbed and the barrier of 4 millimeters is once again established. So, if the thin soft tissue is not properly identified and implant is placed aligning bone surface, as soon as the healing abutment or temporary prosthesis is connected, biologic width kicks in, causing bone resorption. This should be remembered. The first rule is to place 1 millimeter deeper than the bone surface. The second rule is to calculate the soft tissue thickness. Clinically, when busy, this is frequently overlooked. That's the big difference. The third rule, implant platform to occlusal plane. The distance from the retrievability perspective, I prefer to use SCRP type prosthesis. Considering proper thickness abutment and prosthesis, 10 millimeter or more space needs to be secured. After surgery, During model evaluation with technician, this can be recognized. If you use guided surgery on the program, as you align or position implants, we can measure the distance from the implant platform to antagonists and the soft tissue surface easily, so we can plan in much more details. In the picture, the height of D1 and D2 can be measured in advance. If that is the case, the accurately planned implant needs to be placed perfectly. To do so, there should be no errors in the data. Currently, the guided surgery uses the merged data of CBCT and the surface scan data after they are acquired without distortions, has information on teeth and bone surface, and important anatomic structures, but not software tissue surface. CT data is the basis for accurate implant positioning after merging. The surface scan data has information on teeth and soft tissue surface but not bone surface. The scan data is the basis for fitting of a guide in tissue and prosthesis. So, these two types of data need to be merged accurately to conduct the guided surgery accurately. The common information in the data is the reference points for merging. The information is teeth. Based on the teeth, the data is merged, and I'll show you how to design a guide. This patient is my patient. At number 22, the tooth has severe mobility, so the plan is to extract the tooth and implant will be placed right after extraction. Guided surgery will be used, not the conventional surgery approach. On the surface scan, the tooth is reduced or deleted. On CBCT, occlusal plane is aligned. And then CBCT data and surface scan data are merged. Automatic merge is very efficient these days and very accurate. However, sometimes automatic merge can fail. In that case, 3 points need to be decided. As you can see, that will increase the accuracy of merging. After the merging, the merged status, CBCT data will be used. Pre-planned implant with a specification will be included in the CBCT. First, at the bottom, CBCT implant is positioned. After that, more detailed three-dimensional angulation can be done in the upper image, the three-dimensional reconstruction image, and the more detailed adjustment can be made. Implant positioning is almost complete. After that, a hole in the guided template is determined. Now, outline is being drawn for the guide. The insertion path of a guide is determined. The margin is drawn of the guide template. As you can see, three-dimensional guide appearance is preliminarily completed and displayed on the screen. After that, if necessary, surrounding the guide hole, support bar, and at the guide hole, a mesial-distal viewing window can be created through which fitting of the guide and tissue surface is checked during surgery. A window is made and the size of it is adjusted. After the adjustment, the appearance of guide to be printed out is on the display. To prevent errors, the names of a patient in clinic can be included. Like this, both aesthetics and long-term survival of an implant should be satisfied for anterior implant surgery. For anterior implant surgery, I prefer to use a digital one-guide surgery. Most importantly, the data should not have distortions. To fully embrace the guided surgery, first, the CBCT calibration should be done to heighten the accuracy and quality of CT data. If image is already taken, you need to check whether the image has shaking, whether the image was shaken. Before sending a patient home, you need to take the CT data again by scanning it again. There are two ways to acquire data. If the patient's occlusion is stable, using intraoral scanner, you can get most accurate data. The intraoral scanner, whether it goes to the design center in your clinic or to the Osstem One Guide Center, the data can be immediately sent so that accurate guide can be fabricated fast. And if you don't have an intraoral scanner in your office, after alternate impression taking, a model is made to be scanned with a model scanner. Then analog scan data is converted to digital scan data. When occlusion is completely collapsed or in a complete edentulous patient, first I do impression taking and take interjaw relation, and then I convert the data into digital. Now let's look at a case using an oral scanner. Lower posterior region is severely resorbed. Safe distance from the inferior alveolar nerve is measured for implant positioning. As you can see, the amount of bone graft for vertical augmentation is checked to design and fabricate a guide. This is the pre-op image. After an incision is made, buccal and lingual flap elevation, the bone is checked. The guide is used at the pre-planned position to accurately place the implant. Partly vertically exposed implant platform is observed. In general, bone is grafted up to 2 millimeters above the platform. Autogenous bone is combined in the graft material, and the titanium reinforced DPTF membrane is fixed. The flap is released, and the first suture is done. After 6 months, it looks like this. After the flap is raised, the titanium DPTF membrane is exposed and removed, and you can see thickly ossified regenerated bone, which is verified before performing FGG. The second surgery is also planned. If occlusion is unstable and edentulous patient, to acquire surface data to make impression and interjaw relation, a model is made first and then scanned. In this respect, impression taking is preferred because in a surgical guide template, sufficient flange is helpful like a full denture. The sufficient flange increases during drilling the guide's retention and stability. Here, impression taking is required because the information can be acquired through boulder molding. Here, the surgical guided template is made in this way with a sufficient flange, so sitting on a residual alveolar bone is stable. Second reason is interjaw relation. That means the vertical dimension from CR range can be easily acquired. In the video, the patient's anatomic structure, for example, by referencing nasal septum or nasal spine on the stable interjaw relation, midline, and temporary prosthesis are positioned. If after extracting a hopeless teeth, we have to wait for a certain period of time until healing, for function and social activity, treatment denture may have to be used. And if a patient has adjusted to and is satisfied with the treatment denture, As you can see, radio-opaque markers are attached to the denture surface, and the denture is scanned with a model scanner to merge. In this case, very stable outcome can be obtained. So, in summary, workflow is as follows. After analog impression taking, good quality treatment denture is fabricated. The patient uses and adjusts to the denture for a couple of months. Radio-opaque markers are attached to the denture, which is scanned with a model scanner to use it as surface scan data. Now, to utilize digital implant surgery, what would be the most appropriate indications at a basic level? Maxillary right side lateral tooth has severe inflammation. Based on the patient's diagnosis, based on CBCT, severe external resorption is observed. After extracting the tooth root, the inflammatory tissues need to be removed. In this case, if I raise a big flap from marginal gingiva using a vertical flap, interdental papilla and the buccal marginal gingiva, the buccal bone tissues, which are very important critical microaesthetic structures, can be unnecessarily lost. In this patient, there is a trace of apicoectomy done in the past. Along the scar line, a flap is raised and the inflammatory tissue is removed. Socket preservation is done and flap is closed. If the plan is not for immediate placement of implant, socket sealing technique using round FGG will help for immediate supporting of papilla and marginal gingiva. Let me show you a video doing a surgery. As you can see, a splinted bridge with a cantilever for missing teeth is prefabricated to promote healing. Bone particle from socket preservation, and after FGG, soft tissues are healed for 4 months. Guided template is prepared to do one guide surgery. Appropriate flap design, socket preservation, and socket sealing technique are used to preserve critical aesthetic anatomical structures. So flapless surgery is planned for placing implants. By doing the flapless surgery, we can position the implants as planned, and for that, the best solution would be one guide surgery. A tissue punch is used to remove the top tissue. After mounting the Osstem one guide template, sequentially drilling is performed. First, the bone flattening drill is used to flatten the surface of the bone where drilling needs to be done. Tapered drill is used to expand the hole sequentially. After checking if the implant is sufficiently wet, the implant is placed. Here, the hole of the guided template is in line with the yellow line of the driver. Even implant's hex position is properly placed as planned. That is very important. In this case, before implant placement, in advance, the customized titanium abutment, that is the Osstem, 1-feet abutment, and temporaries were fabricated. Hex type titanium customized abutment is prepared, so the hex positioning is very important when it comes to the internal connection type. When the abutment is accurately connected, the subgingival critical contour of the abutment presses down the marginal gingiva appropriately to automatically performing the tissue molding. 20 Newton or more initial stability is achieved for the implant. it looks like as if the tooth is prepared and the abutment appearance looks really beautiful. After that, the cantilever splint crown used by the patient before is mounted after the inside is reduced. The patient used the temporary before the surgery. After implant placement and connection of abutment, the temporary fits the position very well, means the accuracy of Osstem One Guide system is excellent. The final prosthesis is beautifully completed, giving the patient a lot of satisfaction. Let me summarize the digital implant surgery. First, through the computer-guided surgery, more information can be considered to position the implants. In those positions, accurately, implants can be placed. When you do the conventional surgery, a lot of skill and experience is required. Using the guided template, beginners can achieve good results, as good as or even better results more quickly. That's the advantage. Secondly, for accurate outcome, merging of undistorted data is very important. Merging and technical information will be delivered in the offline lecture. Thirdly, temporary prosthesis can be prefabricated before surgery, so right after implant placement, for the anterior where immediate restoration is required, or for complete edentulous case where implant placement is required. Such cases will be very good indications for computer-guided surgery. Today, navigation is essential in driving. You don't get lost if you go to a certain place for the first time, and it gives you the shortcut. Digital implant is the same. The optimal outcome will be achieved for both the surgeon and patients. I hope this lecture helps you to grow your confidence in digital dentistry and in doing implant surgery. This concludes my lecture. Thank you very much.
함께해 주신 여러분 고맙습니다.